Postpartum hemorrhage and postpartum complications. A legal disclaimer we put at the beginning of all of our presentations. This information is for general and educational use only. Content is not intended to substitute for professional, legal, or clinical advice. We strive to keep our information as accurate and timely as possible, but make no promises and guarantees it works for your local unique situation. As an introduction, postpartum hemorrhage and the complications postpartum are critical aspects of midwifery care. It affects how we have the knowledge and skills to identify, manage, and intervene in those emergencies. Postpartum hemorrhage is the leading cause of maternal morbidity and mortality around the entire world. Midwives play a vital role in preventing and managing through our evidence-based personalized practices and our swift actions of being in the front lines and that one-to-one labor support, the resources we have available, the autonomy we have over doing skills and drills to keep our policies and our team skills up highest level. Postpartum hemorrhage, there's different types. There is the basic definition: you've lost excessive amount of blood after childbirth. For a vaginal delivery, 1,000. For a C-section, 1,500. There are some newer guidelines coming out of or I should say there's older guidelines still out there that some of the practices use of 500 as the criteria for a vaginal delivery and 1,000 for a C-section. But recent guidelines have actually gotten more lax and a more cushion of what that criteria is. There's different types of postpartum hemorrhage. There's the primary postpartum hemorrhage. It occurs in the first 24 hours. It's typically caused by uterine atony, the uterus getting soft and boggy and not clamping down on the blood vessels that were from the area of the placenta separating. The birth canal trauma, so that could be a cervical laceration, could be a perineal laceration, especially a deep sulcal tear near that posterior fornix that you just didn't know and didn't visualize well. Retained placenta parts, clots, coagulative disorders, bleeding issues, anemia, and then the secondary postpartum hemorrhage is typically after 24 hours, and it can be all the way up to 6 to 12 weeks. Those are those ladies that are home and then they come in bleeding out. Maybe they had a retained placenta part that now got infected. They need an emergency D&C. They were bleeding all the time, but they didn't think it was enough to be concerning, but it's been happening constant because it was that arterial bleed. They had a hematoma. Most of the time you're going to have pain, you're going to have underlying symptoms. They don't feel good, they're lightheaded, they're dizzy, they're pale, but it's those people coming in that have that excess of blood loss days to weeks after the delivery. Early signs of postpartum hemorrhage: heavy bleeding, soaking multiple pads in a short amount of time, particularly an hour, blood pressure being low, fast heart rate, clammy skin, pale, lightheaded, dizzy, not producing as much urine. Their body is trying to just protect itself, and so we need to go through our symptoms. Okay, if you're having heavy bleeding, is the uterus firm? Are there clots in there? Are there retained parts? Is there a laceration I'm missing on the cervix, the perineal area, the vaginal vault? You need to go through your signs of symptoms. What are they telling you? Why? I mean, there's times they can have postpartum hemorrhage because of a hematoma, where they're bleeding internally and an arterial bleed under the skin, but typically you'll have a lot of rectal pain, back pain. There will be an internal bleed where there's bulging at the site where the bleed is happening. It's just not actively coming out of the vagina. You want to just have an overall background understanding of the possible sites and why. So when that placenta separates, there's a lot of blood vessels that need to be clamped down quickly. That was that opened, raw, exposed area. And so when they have bleeding and they have that lochia and they have that transition of tissue discharge after postpartum, those next few weeks, it's from that placenta site healing. So if you're having the most common reasons that you'll have a uterine bleed is because the uterus isn't contracting down efficiently. We have far less bleeding in home births. It gets a little bit more in birth center, and then it's highest rate in hospitals for a combination of things. We have low risk healthy women in birth center home settings. I truly believe, because I practice in all settings, that a home setting, it's very instinctual. The brain is in a primal sense. The mom is skin to skin. There's delayed cord clamping. The baby breastfeeds right away. The mom can deliver how she wants and she feels safe. There's not this fight or flight adrenaline occurring. We rarely have postpartum hemorrhages at home. I rarely would have to start an IV. I'd rarely have to give some meds. It was glorious. It was beautiful. As soon as we went to the birth center setting, I started seeing it a little bit more. I'm still giving her amazing physiological care, but it's a new setting. It's not her space. It's not as instinctual as a home birth is. And then we maybe have different regs we have to follow with the birth center versus home. Like some birth centers are required to do more active management of labor in the third stage than other places are. Their anemia criteria, their protocols may be more conservative based on their medical director versus a home setting. And then in the hospital setting, you have the high risk people, you have the sick people, you have inductions, you have interventions, you have the medical model of care. You're going to have more bleeds, you're going to have more complications, you're going to have induction where the uterus has been getting oxytocin for a couple days, and when it's time for delivery, those receptor sites are tired, they're exhausted from the IV synthetic oxytocin going in their body, and it's just not going to clamp down as well. Twins versus a singleton, you're going to have more bleeding because that uterus has just been stretched out more and has to clamp down on a larger surface. So there's a lot of variables, there's a lot of things to consider, but typically it is the postpartum hemorrhage. If you've done all your meds, your uterus is still not clamping down. I've done bimanual compression often where I'm trying to manually hold that uterus hard against those blood vessels till the medications can kick in. There are tamponade techniques, there's the Beckery balloon, there's the Jada, where you're actually going on the inside and you're inflating this balloon that's putting pressure on those blood vessels that aren't, when the uterus isn't clamping down, that site for the placenta is going to keep bleeding and bleeding and bleeding. And then there are rare extreme situations that you can't stop the bleeding. It's boggy, you can't find the bleeding source, there's clots, there's a placenta accreta, it won't separate, you have to go to surgery. And there's extreme situations of a hysterectomy where the organs just need to be removed because they're bleeding her out and they can't stop it. And then sometimes you get in this vicious cycle of a DIC where you actually start lowering the platelet levels because of all the bleeding, and then the body can't clot off. Even though you're giving them a bunch of blood, it's just going in and out of them. We would do D-dimers, and we would do like just even putting some blood from the patient in the OR on just a tray, and we would time how long it took to clot. And the longer they're bleeding, the DIC, that platelet aggregate issue, gets higher and higher. So you get in these cascade challenges sometimes with bleeding if it gets pretty significant and severe. So uterine atony is the most common reason. The uterus isn't clamping down on those blood vessels from the placenta site. You're going to be doing uterine massage. You're going to be given uterine tonics. You may have to do bimanual compression until the meds kick in. You're going to be looking at all the aspects like birth trauma, the tears, the cervix, the vaginal vault area, arterial bleeds. There's also birth trauma in a psychological sense. Like I don't think we give enough credit for postpartum hemorrhages with fight or flight response. I get it all the time in these hospitals, and people that are abused and have no autonomy and so much fear with birth. There's so much more postpartum hemorrhages. I have ladies, their uterus is boggy, and as soon as I start talking about a needle and doing a repair of her laceration, she starts having a ton of bleeding because she goes into a panic attack, because she is getting anxious. And I just have to pause and I have to say, okay, you're safe, you're okay, let's take some slow, deep breaths. And the power of the body getting out of that fight or flight response can clamp back down the uterus. So we have to be careful when we're doing these emergency situations and we're talking as a team, our medical lingo, and doing all this stuff to our patients. And midwives are so much better at this than the traditional hospital healthcare system is, but when I have an emergency, I'm talking to the patient, I'm talking to the family, and my team around me, my assistants in a birth center and home birth, and the nurses in the hospital setting, they're knowing their steps of what to do by how I'm talking to the family. I'm like, I'm so sorry, you're bleeding a little extra. I'm going to be rubbing on your tummy. I know it's super uncomfortable. I got to get this muscle to tighten up. The nurse is going to be giving you a little shot in the thigh. She's going to be giving some medicine that's going to make your uterus firm up called oxytocin. oxytocin in this fluid bag. She's going to put some little tiny pills on my delivery table that I'm going to put in your rectum that'll also help to clamp up the uterus. And by having that communication with the family, they know you're confident, you've got the skills, you know how to handle this, and they've built up a trust with you that I'm like, I will tell you if I'm worried. I'm not worried. You had a great iron level. It's normal to have some bleeding after delivery. Your body is meant to compensate for this versus you had a low iron level. I'm going to do active management at third stage when you're delivering after placenta because you don't have as much to lose as another person. And then when the bleeding happens with that more riskier person, I was like, remember how we talked? I'm going to be more aggressive. I'm going to be more preventative. You have some bleeding from some clots. I'm not going to wait as much for your body to replace and take this out. I'm going to do a manual exploration. It's going to be uncomfortable, but it's really important. We can't have you continue bleeding. So there's going to be stages of ruling out what are the possible causes of the bleed and the highest priorities, her history, how aggressive you have to be, what's the situation, the setting you're in. Retained placentas can be tricky because especially when it's partially detached or you have like a placenta accreta, percreta, where it's growing past the uterine wall, it doesn't separate. Even if you do a manual, like you have an art to this. You can't try to rip and shred and pull from something that doesn't want to separate. So there's definitely challenges. It's not, I mean, on my top of my list, I do not like doing manual explorations and I hate doing repairs. I hate putting needles in mom's bottoms. I hate especially labial tears and they don't have an epidural. Like this is torture to me as a midwife, but it's also important. I don't want her bleeding out. I want her to be safe. I have to balance my own fears and biases and stigmas with some of these things. By me hurting her for 10 seconds will stop her from bleeding, that kind of mentality. Coagulative disorders. Certain people have certain conditions that make it so they don't clot as well. They have a low platelet level. And depending on your birth setting, some of these ladies shouldn't be delivering in the home, in the birth center setting, should only be delivering in the hospital. We can be more proactive with watching their iron levels and being more aggressive with iron supplementations, infusions. In the Indian reservations where we had tons of postpartum bleeds, we would be very proactive to get their iron levels, their CBCs, their hemoglobin levels as high as possible because we knew that they were going to lose a little more. Like everybody had active management at third stage. Everybody got all the meds because by the time we weren't preventative, and I'd have ladies weekly lose 3 to 5 liters of blood and constant blood transfusions. And you have to look at your population. You have to look at your community, your situations, and determine how to take care of them. Uterine inversion is extremely rare. It's where the uterus turns inside out. The 2 times I've ever seen it is where a physician, as a labor and delivery nurse, was pulling very aggressively on the cord at delivery time and it wasn't ready to detach and actually turned the uterus inside out. It's cold shocked. It just freezes. Even if you try to push it back in, it's really hard to get it to clamp down. And thank goodness I rarely see this as an issue with midwives because we're not nearly rushed to try to get everything done after the baby delivers to move on to the next place. We're waiting for physiological signs of separation. So I've never seen a uterine inversion, involution in the out-of-hospital setting. In midwifery, the few times I've seen it is physicians, and it's caused not naturally, but because of what the physician is doing. Management of postpartum hemorrhage, prompt systemic response is crucial. We need to be preventative. We need to be proactive. We need to have good conversations with our patients prenatally. How you're going to handle a postpartum hemorrhage in a home setting, birth center, hospital, certain risk factors is going to be different based on her beliefs and her resources and her health. So a home birth mom is not going to be okay with active management of everybody aggressively like they do in the hospital setting for medical management. There's a reason they chose a home birth. There's a reason they chose you as the care provider, and you have good education. You make sure she's super healthy. You make sure you're decreasing the risk. You're not inducing her. You have the healthiest of healthy ladies. Her iron level is excellent. You've got cushions that physiological management of that birth and that potential hemorrhage risk is more of a low risk versus managing someone that is really sick, low iron level, has high risk of postpartum hemorrhage. They're going to be on an active active management of third stage because you don't want them to bleed out. It's much harder to play catch up than to be preventative and be routinely, okay, I'm going to give you some Pitocin, I'm going to give you some misoprostol. You're not bleeding yet, but you've had 7 babies before. You bled the last 3 deliveries 2 hours after delivery. Your uterus gets tired easily. Those receptor sites get tired easily. I want to be proactive with you. So you individualize the situation, you have conversations, you empower your patients, and you educate. When the actual bleed is happening, you're going to determine the rankings. If the placenta is still in, this picture is of an actual manual removal of a placenta. And that's why I always laugh when you put a glove on. You need a cow glove if you're doing a manual exploration and getting clots out, because it's uncomfortable. Like you can see your entire arm is going up inside her uterus, depending on where that placenta is located. If it's in the front, if it's at the top, it's in the back. It's important for you to know ultrasound and location for your just not going in there exploring everywhere. I usually follow the track of the cord for the placenta, and then I just go from there. But you have to be able to know your meds, your team's skills of using those meds, and what you can have available. Like some of the meds, Methergin, if it's IM, it's got to be refrigerated. So obviously a home birth practice can't utilize that. A birth center rarely can because it's expensive. It's mostly the hospital setting. You can do oral Methergin, but it's for like the next 6 to 8 hours, and the next couple days it's a preventative aspect, so you don't want any more bleeding for them. So there is different things to consider. You want to look at, like, okay, you've tried everything. The uterus is still boggy. You've done a manual exploration. The placenta is intact. There's no clots. Does she have an underlying coagulative disorder problem? What is going on? And you need to get extra resources and get a physician involved. Consider going back to the OR. If you can't, if all the meds aren't working and they're continuing to bleed, they have to go in and figure out what's going on. Blood transfusions, some places have more resources than others. High risk, high volume hospitals have more blood transfusion resources than an Indian reservation. I'm currently in the Virgin Islands doing a hospital locum coverage, and they've got 2 units for the entire hospital. So you have to think, you have to plan ahead. If you know someone can't be shipped out, and you know they have a high probability of needing blood, prep for them, plan for them, coordinate the best of your abilities. IV fluid replacements and making sure you can replace the blood volume and stabilizing their blood pressure, close monitoring of them, continual oxygen levels, the heart rate, respirations. You want to be able to keep a close eye. It's needed in a higher acuity facility. So there's other things to think about when we talk about postpartum complications, no matter what setting you practice in. We want to think about infection. We want to wash our hands. We want to wear our gloves. We want to reduce the risk of exposure. Most of the infections come from us pushing the germs from the vaginal vault up into the uterus when we do that vaginal exam. When they deliver in the hospital setting, there's much more risk of nosocomial infections and what's on the surfaces, and that lab draw person coming in your room and they were just on a different med-surg floor that was a patient with C. diff and they didn't wash their hands properly. Like, babies and moms get infections from being exposed to germs. So like in a home setting, you're far lower risk of infection, and then it increases a little bit more with a birth center. It increases the highest with a hospital setting because it's just the germs, the ventilation system, the sheets, the people coming and going from your room. And then it comes too with like just the midwives. Like if the midwives, they alcohol swab things, they clean their equipment in between use, they sterilize their instruments, they wash their hands. These are part of your direct accountability protocols, policies to reduce your risk, minimizing vaginal exams, catching signs and symptoms of a bladder infection, and getting them antibiotics before it goes into a kidney infection. Like, these are things we can do to help reduce, and especially postpartum. I get a lot of it with mastitis that we try to manage it naturally at home, and by that point it's gotten too far. She needs antibiotics, and many times she needs antibiotics in the hospital setting before it becomes an abscess, before it becomes septicemia. Like, especially if she's had mastitis a few times. I mean, I am personally biased. I've had mastitis 3 times in my second breastfeeding experience with my son, going back and forth from Alaska, the jet lag, the time changes. And I can tell you what, every single time I got it, I got sicker and more aggressive. And so you have to look at the individual situation. Is it endometritis? Is it a uterine infection because of retained parts, because of just normal bacteria from the vaginal area getting up into the uterus, and she's immune compromised, being postpartum? You need to look at the situation and figure out, is it just the general flu bug that's going around with everybody else? Or is there redness on her breast? Is her uterus really tender? Is her bleeding increasing? Is her discharge have a foul smell to it? Is she making less milk for her baby? That will help you determine which pathway to look for these infections. For thrombosis, it's extremely rare, but we're getting more and more coagulative disorders during pregnancy, after pregnancy, because of COVID, the vaccinations, all the changes that have happened the last few years. And so we are getting a rise of PEs, of miscarriages, of blood clots. And so we need to watch for these symptoms. We need to educate our families what to watch for. It's not always just the classic redness in your calf and that tenderness and the Holman sign. It could be in different locations of the body, and it could be mild, and then it moves and shifts. So our goal is to be preventative. It's to help make sure that they're not sitting around for long periods of time. They're moving their feet, especially after C-sections, after complications, history of coagulative disorders. We need to help with the circulation in the body. We need to watch for those signs and symptoms and then get them into the most appropriate place. If you think they have signs and symptoms of blood clot, they need an ultrasound. They need evaluated by an ER, a higher acuity provider, pretty quickly. Retained blood clots, hematomas, we want to look, is there pain? Is it increasing? What are the vitals like? What's the vaginal discharge like? We want to be able to look at the site of the bleeding. Maybe there is an unresolved tear. There's a clot left in the uterus. There is, especially if they have rectal pressure and there's like a bulge in the vaginal area, it's very tender when you do a vaginal exam. You worry about hematomas. So like there's different things to assess and consider. Where's the pain at? Is it worse with pressing? Is it worse with moving? Is there certain positions that are making it better and worse? This is part of our assessment skills. On the mental health component side, mental health disorders are going through the roof for our population as a whole. Our society is demanding more and more and more out of us with less and less time, and the human capacity just can't keep up with it. So pregnancy depressions are increasing, postpartum depression, psychosis, mental health disorders are through the roof. And we want the moms and babies to be a strong bonding unit. If she feels like she can't take care of the baby, she feels like she can't feed the baby, she did a horrible job birthing her baby, she's a bad mother, she has worries of harming her baby just because her baby would be better if she didn't exist. Like, these are things we have to watch for, and we have to have conversations. It's a cascade effect. If she's got all kinds of stress in her life, she's going through divorce, she's moving, her husband's cheated on her, she got a new job, there are financial strains, she's not eating well, she's got some other complications, stuff's going on with her kids, like, you're going to have more mental health disorders. Postpartum, bad birth outcomes, C-section, she wanted a home birth, she got stuck delivering at the hospital, they treated her like crap, she can't breastfeed, her iron level is low, so now she's got anemia, she's more prone to an infection, she's tired, she's exhausted, she's not eating, she's not sleeping. These are all components that just escalate depression. It's normal to have highs and lows postpartum, but we have to watch for when these women, and sometimes it's simple things. This postpartum care and education is not emphasized in the United States healthcare system. Midwives do a much better job of taking care of our moms and babies, their mind, bodies, spirits as a whole. We are so much better at spending more time with them, educating them before the birth, talking about options, empowering them, and it has a ripple effect. Like, I want more moms having the option of midwives and not time constraints, and more postpartum care resources, postpartum doulas, nursing home visits, midwives that come and not just see them in the hospital and then 6 weeks postpartum. Like, we can be preventative to help. We can coordinate meal programs for their family with their aunts and get some things going. We can get some support networks so she can get some naps while dad's working in the daytime so she can take care of the baby at nighttime. Like, hitting a schedule, talking about family planning. Like maybe she's ready to have another baby right away, maybe she's not. Like we need to be able to talk about every aspect of postpartum care needs for her and the baby and be preventative. And then when those complications arise, we're taking care of them quickly and we're doing it based on evidence. Ongoing training and simulations are really, really important when it comes to postpartum hemorrhages and the complications of postpartum. We need to be proactive, watching for potential risk factors, getting their iron levels as best as possible, looking at risk factors and birth settings and resources and skills of the providers taking care of them. Practice skills and drills, not just for the traditional emergency situations, but also what if you have a lady that comes in or she calls you on the phone and says she is worried about herself and harming her baby? What are you going to do about it? What are your resources in the area? Who are you going to call for emergency situations with those postpartum complications when they're at home and you're not by them? So as an overall conclusion, postpartum hemorrhage and the other postpartum complications can cause serious complications for our mothers and our babies and our family units as a whole. We want to look at the risk factors. We want early recognition. We want education, and we want to have the knowledge and skills to do prompt interventions when they are needed. Understanding the causes, recognizing the signs and symptoms, and mastering those management skills is what makes midwives have amazing outcomes in the birth center, home, and hospital settings.